Assalamu alaikum everybody. Let us formally begin this webinar. We are now live on Facebook as well as and people are they have been waiting for quite some time as well. So now when we are live, you all can join and share that it's gone live, so you can connect directly to our Facebook link. And the topic is very important today: gastroesophageal reflux disease in pregnancy, which is one of the most common occurrences, and everybody, I'm sure, every doctor, not just OBGYN related person, but every doctor and almost all pregnant women in some part of their pregnancy face this dilemma. So this is a very important topic, and what's more important is that we have two of the biggest names of the fraternity with us today. I'll be introducing them as we begin our presentations. Professor Ghazala Mahmood and Professor Sayyida Batul Mazhar. Thank you very much, madams, for sparing your precious time for this activity. And I hope you both had a lovely Eid. और ये ईद सबके लिए बरकत वाली इस तरह साबित हो कि the decline we are seeing in COVID, अल्लाह करे कि ये बिल्कुल eliminate हो जाए, not just from Pakistan, बस इंशाल्लाह अल्लाह करे तमाम दुनिया से तमाम लोगों को सेहत के साथ जिंदगी के साथ ये disease जो है ना, because everybody has faced it, and doctors community, so उन सब के लिए बहुत सारी दुआएं हम अक्सर हम हमेशा करते हैं और उनको दुआओं में याद भी रखेंगे. Academic हमारा चलता रहा हमेशा से, and SOGP Rawalpindi Islamabad chapter has been very active, not monthly but quite a few times in a month. So all hats off to both of you and the cabinet of the chapter, who has always been apt, and चाहे सड़क पर हो, चाहे ऑफिस में हो, चाहे थिएटर में हो, चाहे कॉलेज में हो. So we will begin our webinar now. I'm sure the team has given a go ahead that we have the live audience with us now. So this is going to be a presentation about GERD in pregnancy, and it will be a continuity of presentation there, and both our speakers have coordinated and put up a wonderful presentation which is full of knowledge for everybody. We will begin with our Professor Meritorious, Professor Ghazala Mahmood. She's currently the professor and head of the department at Fizaiya Medical College, Air University, Islamabad. She has served as gynecologist and obstetrician in Lady Wellington Hospital, Lahore, Rawalpindi Medical College, and at Pakistan Institute of Medical Sciences, Islamabad. She has been a professor of OBGYN since 95 and HOD since 96, and a meritorious professor since 2002. She has been the Dean of OBGYN, then Dean of Medicine at faculty at Quaid-e-Azam University, and then Executive Director of PIMS. She has worked with Her Majesty the Queen's gynecologist as well. And later then she joined as a research fellow in Oxford University. She has published widely in local and international journals, and postgraduates and undergraduates, we all are taking benefit from her. She has been awarded 2 gold medals. And Professor Ghazala Mahmood, I'll request कि हम आपसे begin करें, and then when we'll reach to the part of Professor Dr. Sayyida Batul Mazhar, I'll introduce her then as well. So, Madam, should I start the slide share?
Yes, please. Can you hear me, Saima?
जी Madam, आपकी आवाज़ clear है.
Okay.
It just takes a minute or two. So,
okay. Thank you very much for this generous introduction. And I think it's time to talk about the subject we're here on. So let's have the slideshow.
Madam, can you see it?
Yes. No, not yet. Can't see the slides.
Okay, let me set.
While we start, let's say Bismillah Rahmanir Rahim. Assalamu alaikum to all my colleagues, young and old. And I think yes. Can I have the next slide, please? Uh, Gastroesophageal reflux is the subject we are going to talk about today. Uh, Here are the 5 learning objectives which we have in this presentation. I'll be talking about the quality of life and its prevalence, difference between physiological and pathological GERD, then physiological changes in pregnancy and what impact they create on the gastrointestinal tract, the gastroesophageal reflux during pregnancy, its prevalence and symptoms, and finally, the management of GERD and the role of lifestyle changes will be discussed by Professor Batul Mazhar. Saima, you have the control over the slides. Can I have the next slide?
Ji, madam.
Well,
Can you see?
yes, thank you. Now, we need to understand the two terms GER and GERD. You must have heard the word GERD very commonly, but I'm sure once in the clinical scenario and having graduated for a while, the GER is not widely used in our obstetrics. So the gastroesophageal reflux is practically defined as according to the NICE guidelines. It's the normal physiological process that usually after eating in healthy infants, children, young people and adults takes place. And when we take GER, it is common in infants than in older children and young people, noticeable by the effortless regurgitation of feeds in young babies. Now I have a personal observation and experience of GER in young babies. My granddaughter, she was a small for dates child, and she suffered from GERD that her mother had to take time off from work for almost a year, and for 6 months, she wouldn't allow anyone else to handle her, especially immediately after having fed her 1 or 2 ounces even. She would straight away throw up. So, to tell you honestly, it is a very taxing disease in the newborns and the young infants, and a lot of effort has to be put in to bring them up. Fortunately, now the little girl is 3 years old, and still she does have problems in having a larger meal. The second important term is GERD. So GERD, we commonly use it, and it occurs when the effect of the symptoms are severe enough to merit medical treatment and affects the quality of life. So we need to understand the difference between the two terms. This is a simple diagram which talks about the physiology of the stomach. This is the acid, and there's a air bubble which prevents it from entering the esophagus. So a, con- a condition in which acid gastric fluid flows backwards into the esophagus, resulting in heartburn. The sphincter opens and allows reflux. Next slide, please. Now, different colleges and countries have tried to define it. The, the Montreal definition of GERD, that is the Canadian definition, is that there are troublesome symptoms or complications are present regardless of the symptoms, that those syndromes are caused by reflux. So it develops when the contents caused these symptoms. They are divided into two main parts: the esophageal syndromes and the extraesophageal syndromes. The oesophageal syndromes, as we understand, are symptomatic syndromes, and like the typical reflux syndrome and the reflux chest pain syndrome. However, syndromes with esophageal injury, which actually causes changes in the mucosa of the esophagus, reflux esophagitis, reflux stricture, chronic irritation leading to a stricture, Barrett's esophagus, and chronic inflammation leading to adenocarcinoma. However, the extraesophageal syndromes are very interesting. Someone will be complaining of reflux cough, laryngitis, asthma. These conditions, these four conditions, have an established association with GERD. And believe me, if you may have prescribed uh, bisphosphonates to your patients, and you know the uh, instruction is for bisphosphonates to take it empty stomach early in the morning and to stay up and about for a couple of hours, maybe 1 to 2 hours before taking any further food. Those people who fail to take these precautions, uh, that can cause chronic laryngitis and chronic cough. And I have seen patients being treated for GERD for a number of months. Thank you so much. Can you hear me now? The noise has gone. Thank you. I have seen patients being treated for a couple of months with uh, anti reflux medications, and then they were free from their laryngitis and cough. So, this can be a really disturbing problem, but the solution is uh, medication and simple. Now there are different stages of GERD, and we can measure the percentage of GERD sufferers with the quality of life and what are the treatment options. The stage one, that is mild GERD, and the quality of life is good, and just changing their diet and lifestyle will help them. In stage two, with moderate GERD, again, they can manage with medications and change in diet and lifestyles. Got it back.
Got it back, madam?
Yes, thank you. So then we have GERD 3, when there is severe GERD, the quality of life is low. And here you need not only the first three things, including medications, you need a GERD specialist to treat this with a number of other medications and treatment options. And finally, the worst case scenario is the precancerous or the adenocarcinoma, which may end up in a surgical outcome. So, what about Pakistan? In Pakistan, uh, there are a number of data available, but I'll share a study conducted between June 2010 and 2011, February, across 10 cities of Pakistan, and around 1,010 patients were enrolled based upon the typical history of GERD symptoms. This was, in this survey, 84.4% reported a history of dyspepsia, while 72.5% had gastroesophageal reflux disease during the preceding year. However, there was a family history of acid peptic disease reported in 24.2% prior to the consultation, and 52% patients were on PPIs. ये क्या alarm दे रहे हो? Associated risk factors included tea intake and NSAIDs. People just take NSAIDs for minor reasons and are frequently taking it, though they really injure your stomach mucosa. The lower esophageal sphincter regulates the food passage from the esophagus, as we can see here, to the stomach, and contains both intrinsic smooth muscle and skeletal muscle. Episodes of transient lower esophageal sphincter relaxation are a normal thing, but it occurs more frequently in women with Gerd, causing reflux, gastric contents into the esophagus. Next, please. Now, what is the difference between, this is a second point, what is the difference between physiologic versus pathologic GERD? Brief episodes of acid reflux occur in healthy subjects. It's a normal postprandial period, and they are short-lived episodes, and the reflux remains asymptomatic. There are no problems. It happens all the time after a meal, especially a full meal. So, and it does not result in esophagitis, and it corresponds to what is known as the physiological reflux. However, symptoms and lesions of esophagitis appear when the episodes of reflux become more frequent and more prolonged. The reflux is then considered to be pathological. So it means if it is more frequent, it is more prolonged, it becomes a disease. Next slide, please. So here you see the difference between physiological and pathological GERD. Next. It's worse in the evening, and there is injury to the mucosa. Having talked about the background of this disorder, we will now focus on GERD and pregnancy. In our textbooks, we normally call this as one of the minor symptoms of pregnancy. But believe me, this minor symptom is not minor. The woman's health, the mother's health, depends upon what she can take in, what is her diet, and what is her quality of life. So I rate it as a very important health factor leading to the well-being of the mother and the baby. What happens during pregnancy? We all know that during pregnancy, the gastrointestinal tract, there is slowing of the stomach. Can I have the previous slide again? There is relaxation of the lower esophageal sphincter. Then we have nausea and vomiting, and we know it is proportional to the HCG level. There's enough evidence. Then there is biliary stasis. There is saturation of cholesterol, then coagulation factors, and increased binding proteins of the steroids and thyroid and vitamin D. In addition, as the baby grows during the second and third trimester, the uterus expands to accommodate that growth. Pressure on the stomach increases, which results in food and acid being pushed back, displacement of the stomach and intestine. There is change in the anatomy, gastric emptying is delayed, and intestinal transit times are delayed secondary to hormonal and mechanical factors. Saima, I didn't hear you clearly. Okay. It is, what is the incidence of this in pregnancy? Is the most common gastrointestinal symptom and can affect from 17 to 80% of pregnant women worldwide. It occurs in all the trimesters, and the symptoms of heartburn may be frequent, severe, and distressing, but serious complications are rare. It's estimated to occur in 30 to 50% of pregnancies. with the incidence approaching 80% in certain populations. And its symptoms are heartburn, regurgitation, nausea, vomiting. It is multifactorial, but the predominant factor is a decrease in the lower esophageal sphincter caused by progesterone, which we know relaxes the smooth muscle. And the mechanical factors play a minor role in early pregnancy, but they do play a role in later part of the pregnancy. Next slide. Next slide, Saima. Yes, I've talked about the symptoms, and some women start having water brush from the beginning, and there is loss of appetite. These are the symptoms which have been listed by the Royal College of Obstetricians and Gynecologists. Next slide. Here you can see in this, in a prospective longitudinal cohort study, evolution of GERD symptoms during the course of pregnancy. This is the control group. Then in the first trimester, it's around 25%. In the second trimester, approaching 35, and 50% in the third trimester. However, in the control, it's to 10%. Then the symptoms of the pattern and association of heartburn, nausea, vomiting, regurgitation is goes on increasing from the first to the last trimester. So the diagnosis is a clinical diagnosis based on symptoms. Investigations in majority will be unnecessary. We don't go for barium studies because of the radiation exposure. At the most, upper GI endoscopy is sometimes indicated, but very rarely, and it tends to recur in the future pregnancies. For some people, there are the signs and symptoms usually resolve at the end of delivery, and for some women, these symptoms can indicate to her that she is pregnant. So the prevalence by gravidity is that here is a study. Okay, the predisposing risk factors for developing GERD are advanced maternal age, advancing gestational age, as I've talked earlier, heartburn. Women who suffer from heartburn before pregnancy face severer symptoms during pregnancy, being overweight and obese, then multiple pregnancy, meaning more pressure and earlier pressure, and women who have previously had one or more babies. Now, what is the evidence? 9 RCTs involving 725 women have been published by the Cochrane Library, and they say that smaller meals, lifestyle modification, and elevation of the head of the bed may help to reduce gastric secretion and gastric reflux. Chewing gum stimulates the salivary glands and can help neutralize acid. So abstinence from alcohol and tobacco are encouraged to reduce reflux symptoms. In other words, gastric irritants should be avoided or minimized. Medications do work to relieve the symptoms, and the mechanism of different drugs are put forward. For example, acid neutralization, increased lower esophageal sphincter pressure, which improves the esophageal acid clearance and promotes gastric emptying, like pro-motility drugs, for example, motilium, inhibit gastric acid secretions, that is PPIs, and prevent reflux of acid and food into esophagus, and alginate reflux suppressant is used. Some traditional Chinese medicines like acupuncture is effective. As you know, that is the treatment for almost any disease through gastrointestinal motor activity and secretions. So that here now we come to the WHO recommendations. I'll be finishing soon. Advice on diet and lifestyle is recommended to prevent and relieve heartburn in pregnancy. This is the first and foremost. Antacid preparations can be offered to women with troublesome symptoms that are not relieved by lifestyle modifications. If lifestyle modifications don't help, try medications. Next. We can, as I said earlier, for prevention or treatment of GERD, elevate the head of the bed, small frequent meals, quit smoking, foods which make the symptoms work, and lying on your back right after eating. Don't lie on your back. Next. This is also recommended by the American College of Obstetrics and Gynecology. I think Professor Batul is going to talk more about lifestyle modification. That's part of the management. So I'll skip this slide. Can we go to the next one? And this is my last slide. Thank you very much. So, how to prevent heartburn during pregnancy? We prevent, and there are lifestyle modifications, medications, surgical interventions, and complementary managements. This is how I would sum up my presentation. Thank you very much.
Thank you very much, madam. We are going to move on, and our in continuity, our next speaker is Professor Dr. Sayyida Batul Mazhar. She's a graduate of King Edward's Medical College and a member and fellow of Royal College of Obs and Gynae UK and a fellow of College of Surgeons and Physicians of Pakistan. She's currently the chairperson of OBGYN at MCH Center, Pakistan Institute of Medical Sciences, and has been the Dean of Nursing and Allied Faculty at Shaheed Zulfikar Ali Bhutto Medical University since 2016. She has a keen interest in academics and research with more than 60 national and international publications in indexed medical journals. She has remained chief editor Annals of PIMS for 8 years and currently is the editor for Journal of South Asian Federation of Menopause Societies. She was the country coordinator for Pakistan for the landmark WHO multi-country survey on maternal and newborn health from 2013, 10 to 13. She was a member of Guideline Committee of WHO for Eclampsia and PPH and member WHO Steering Committee for Research on Maternal Health. Currently, she is the Vice President, South Asian Federation of Menopause Societies and the chairperson of Rawalpindi Islamabad chapter for Society of Obstetricians and Gynecologists of Pakistan. Her special interests include maternal health, subfertility, and menopause. So I'll welcome Professor Dr. Sayyida Batul Mazhar and request her to take on from this onwards. Professor Batul, please.
Thank you, Saima, for a very kind introduction. And I would like to acknowledge the services of Saima. She's managing our chapter very nicely. She assists us in so many things, and we would like to appreciate her input in all the meetings that we've been doing. Thank you, Saima. It's a privilege to follow on Professor Ghazala's presentation. I'll be touching on the management of GERD, and then I'll be talking about sometimes the COVID-19 also mimics a lot of symptoms of GERD and lots of gastrointestinal symptoms. So somehow we are thinking that COVID is gone. We all know in our hearts that it's not going anywhere. It is the sort of a disease which keeps coming back. So we'll talk about it towards the end of my presentation. So may I have the next slide, Saima? So as mentioned by Professor Ghazala, that whenever we try to treat something, our first intervention is always in a very physiological way. So we always recommend lifestyle changes. Whenever we are managing PCOS, the lifestyle changes always come first. Similarly, whenever we are managing GERD, and especially in pregnancy, the lifestyle interventions are invaluable. So in pregnant women, it is very difficult to recommend them to lose weight, but I always encourage my overweight and obese patients who are pregnant to avoid excessive weight gain, and that makes such.
Dr. Batul, आपका mute touch हो गया. हाँ जी.
Okay, are we back?
Yeah.
Okay,
all back.
So, yes. So the lifestyle intervention, as I mentioned, was that lifestyle interventions may involve weight loss when you're non-pregnant, but when you're pregnant, it is difficult to lose weight. But being overweight and obese, you should try to reduce your weight gain during pregnancy to avoid the complications of too much of GERD. Another point is that the evening meal should be early. Usually we have our evening meal around 9 and 10 o'clock and go to bed at 11, and that is a disaster. So anybody in pregnancy suffering from GERD, they should basically have an early evening meal around 6 and 7 o'clock, and then they should be upright, walking about for the next 3 hours, and then go to bed around 11, 12 o'clock, and they're going to be comfortable. Similarly, avoiding high fat content would help, because whenever you have high fat content, the content stays longer in the stomach, and you want the stomach to empty itself before you go off to sleep. So that would be again a very good thing, that the night meal should be light, less fat, and earlier if you want to manage this heartburn in a physiological way and avoid medication. Next, please. So I think nowadays majority of people start PPI therapy very early. I always recommend that first trimester we do not want to prescribe PPIs. If a woman is already taking PPI in the first trimester from before pregnancy, I encourage them to stop it, and we avoid its use in the first trimester. Then there are not really major differences in different PPIs, but when you see into the literature, omeprazole is always said to be the category C in many recommendations, while other PPIs are in category B, but some are now even grading omeprazole in B here and there. So FDA categories tell us how safe it is. So if it is A, it is very safe. With B, it is safe in human beings as far as we have data. With C, you start getting concerned. So we can give PPIs, but please avoid giving it in the first trimester. And then when should we give that PPI? We should give it about half an hour to 1 hour before the first meal of the day. And usually the patient is fine with a once daily dose. But in those who respond partly, we should try to then consider increasing the dose to twice a day, or switch the timing and see whether we switch the type of PPI, the names change, and their pharmacokinetics do change. Similarly, non-responders, if somebody has intractable GERD, then we need to have some recommendation from our gastrointestinal specialist, and their help is invaluable. Maintenance therapy should be given to patients who continue to have symptoms after PPI discontinuation. As I mentioned, they are fairly safe in pregnancy, but avoid it in the first trimester. Next, please. So we should optimize PPI therapy, and upper GI endoscopy in pregnancy is very uncommon, and it's usually not recommended. In selected cases, if we feel that there is a bigger problem, as mentioned by Professor Ghazala, that GERD can have non-esophageal symptoms, and if we are not very clear, we can have a multidisciplinary help in selected cases. And the more advanced treatments that are mentioned here are usually relevant to the non-pregnant ladies, where they can do the ambulatory reflux monitoring, and that is not usually routine in our practice. And so it is not usually done in the pregnant ladies. Next, please. Come on to the old is gold. So H2 receptor antagonist therapy is somehow neglected these days. They are considered to be far more safer than PPIs, because we have more experience in their use. They've been there for a much longer time. And the majority of them, ranitidine especially, which is by the trade name of Zentek, that is very safe in pregnancy. And wherever we are, because we usually prescribe PPIs, so if you feel that PPI is not helping completely, then a bedtime H2 receptor antagonist is a good option. Although the problem with bedtime H2 receptor antagonist may be that after a few weeks there can be tachyphylaxis. Next, please. There are other things which are, again, as I mentioned, we have all been using sucralfate, which is known by arsenic. So therapy for GERD other than acid suppression can be considered. In pregnant women, we do give arsenic, which is the brand name for sucralfate, and this has been being given for quite a long time. And we give it half an hour to 1 hour before meals, and usually women respond very well. And the best part about sucralfate is that it is not absorbed. So like isperol, like things that do not get absorbed, we are very comfortable in pregnancy. Again, surgical therapy has practically no role to play for the pregnant ladies, but this is something you need to know, that in GERD, in older women, in older men, wherever there is that problem, there is an option of surgical treatment where they are not responding to medical treatment. They have chronic GERD, and these procedures are usually for very select group of patients. Last of all is a summary of what I have told you. So this is for your information. Whatever is written on this very crowded, busy slide, I have already told you. Next, please. So I'll conclude here by saying that we would basically recommend that it is the lifestyle which is going to have a major role if we change it in pregnancy especially, or in the future as well. It is so much better. If you reduce fatty foods, chocolates, salted foods, fizzy drinks, you're going to be so much better. Similarly, low volume, frequent and slow eating along with consumption of fibrous foods is recommended. So we should I don't know why it doesn't like me speaking, Saima. I think you're doing some naughty tricks on me.
I can't dare that, madam.
So repeatedly, it goes mute on me.
I think आपका बड़ा टच सेंसिटिव आपका है, आपका जरा सा भी कुछ टच होता है ना वो. So I unmute myself to tell you that it's muted. So continue, please. Continue.
So the basic message is that everybody should try to have low volume, frequent, slow eating, elevate the head end of the bed, have an early night evening meal, and so that they should also avoid lying in the supine position and right lateral position shortly after meals. Next, we come on to the this just I've added because GERD is something that is very, very common in pregnancy, and symptoms of nausea, vomiting, dyspepsia. It is something that almost all women complain of. So nowadays, whenever a woman comes and reports any sort of a symptom, I always worry about COVID. Could it be COVID? Is this a symptom, atypical symptom of COVID? So we all know that COVID has come in end of the 2019, and this novel coronavirus has basically really changed the world, and we are now living in a new normal. And gastrointestinal symptoms are a clinical component of COVID-19 which cannot be overlooked. And although we think it is a respiratory disease, it can cause digestive symptoms and it can damage digestive organs. Next, please. So, although we know that the classical symptoms are fever, cough, they're respiratory symptoms, but it is associated with loss of appetite, nausea, vomiting, abdominal pain, diarrhea, liver enzymes are often deranged, and GI bleeding can occur in very severe cases. And about 10% of patients present with GI symptoms alone. And that is why I wanted to give a brief talk on this COVID-19 with gastrointestinal symptoms. And I can give an example of my own हमारा जो security guard था, immediately after Ramzan, because in Ramzan everybody's fasting. So after Ramzan, on the second day of Eid, he had fever, and then he had vomiting, he had diarrhea, and when I saw him, so he had a very bad throat. And I said, why? You're having a sore throat. And he said, no, Begum Saab, this is not sore throat. ये जी मैं उल्टियां कर करके मेरा गला बैठ गया. मैंने कहा तुम जाओ जरा कोरोना टेस्ट करा लो. And he was positive. And he was an ex-army man and he got admitted in MH. And his symptom was what? Nausea, vomiting, and a hoarse, sort of laryngitis sort of a thing. And we are always in denial and always saying कि नहीं जी corona तो हमें नहीं होता, हमारे इलाके में corona नहीं होता, हमारे घर में corona नहीं आया. So we are all in denial. It goes, but it does not go. So COVID is here to stay. So COVID-19 and upper GI symptoms, as I mentioned, that loss of appetite is seen in almost 40% of patients. And it is before the onset of respiratory symptoms, and often you have a delayed presentation. Similarly, nausea, vomiting, and abdominal pain can be a presenting symptom in about 4%. And these symptoms, because they are not very specific and the cause can be multifactorial, so index of suspicion should be high. Next, please. Again, they often can present with non-bloody diarrhea in almost 20% of all patients. And the other very worrying point is that the stool specimens have shown that there was virus in the stool as well. So it comes in secretions, it comes in the feces. So these are very worrying things, and COVID-19 may be mistaken as gastroenteritis with or without febrile illness, and we need to be aware of inflammatory bowel disease, whether this is an irritable bowel disease, this is a malignancy, but do remember that it can mimic anything. That is why it is a novel virus. It's a very different virus. Next, please. What is the pathogenesis of GI symptoms? Whenever you get it, then you are going to ask what is the problem. And we all know that with the latest pathogenesis theory, it is the thrombotic dysfunction caused by this COVID virus, which results in the respiratory symptoms, which also results in the bowel symptoms, because there's small vessel thrombosis, there's hypoperfusion, there is hypotension, shock, and sepsis. And liver damage may be due to the transient hepatocyte damage by the coronavirus, which impairs the liver, bile ducts, which are expressing the ACE2. So that is the reason that it goes and binds there. This is the kind of bowel that you would see when you do endoscopy. And colonoscopic findings include colitis, mild to more severe ulcerative lesions. So it causes serious pathology. It's a multi-system disorder caused by the COVID-19. Next, please. And the biggest concern is that Oro Fecal Transmission, whether it occurs, whether it does not occur, but the virus has been isolated from stool samples, although this is not used for diagnosis. And only half of all patients of COVID-19 have stool detectable PCR. So half of the patients will be excreting the virus per rectally. So people don't really know how much that correlates with the GI symptoms, but still it is the respiratory swab which is diagnostic. Stool tests are not really being recommended for this purpose. Next, please. And I don't know what about our other colleagues. In OBGYN, repeatedly what happens is that we have patients presenting with preeclampsia, we have patients presenting with suspected sepsis, and we have deranged LFTs. So keep the index of suspicion high for COVID-19. We've had, false results like, one patient is getting hepatitis E positive as well, hepatitis A positive as well. And then you say this laboratory is doing a major error. It cannot be that one person has two kinds of hepatitis at the same time. It may be a rare entity, but we need to be vigilant that whether this is cholestasis, whether this is preeclampsia, whether this is sepsis affecting the liver, or is it the COVID-19 which is presenting atypically. So there are confounding factors, especially in Pakistan, where there is often pre-existing liver disease, and there is presence of myositis, ischemic hepatitis, and then there is the misuse of antibiotics that we are used to in our country. We are basically very happy with overuse of antimicrobials. So keep your index of suspicion high and rule out COVID-19 in addition to preeclampsia, viral hepatitis, and sepsis-related liver dysfunction. Patients with digestive symptoms, it has been found those with COVID-19 and GI symptoms have a longer course between symptom onset and viral clearance, are more likely to suffer from severe pneumonia or ARDS, and more likely to test positive for COVID-19 viral RNA in the stool. This does suggest but does not confirm direct infectivity of the virus on the intestinal tract. So we have to keep this in mind. Kind of image that you would see, that abdominal wall imaging was often performed for inpatients with COVID-19. And when you do an abdominal wall imaging, you also see the rest of the organs. And the CT abdomen and pelvis revealed imaging findings in lung bases of peripheral nodular airspace and ground glass opacity. And when you looked at the bowel, it also had thickening, ischemia, pneumatosis, and portal venous gas. So, uncommonly in such patients where they had colonoscopy or laparotomy, the evidence of thrombosis was seen. So, this is a very, very serious disease, and we hope and pray that Pakistan is going to be free of corona in the near future. We can be optimistic and pray to Allah. That's what Pakistani and being good girls, we all want to hope for. Next, please. So, data emphasizes that patients with new onset diarrhea and possible contact with COVID-19 should have an index of suspicion for COVID, and these patients should self-quarantine and seek medical care. Optimally, testing for COVID-19 should be considered using both respiratory and stool samples if and when they become available. Currently, we only use the respiratory samples, but this is again very important that you have to keep your clothes clean. You have to make sure that in the toilet you use all the hygienic principles. If you're sharing the toilet with other people, again there is the you could transmit it if you're sharing toilet facilities. So please be very careful with hand washing, and especially in shared toilets because of the risk of COVID. Next, please. Thank you very much. So happy to answer any questions or.
Thank you very much, Professor Batul. Professor Azala, I'm unmuting you as well. And we have quite a few, participants on our Facebook, as well as a few of our seniors have joined us on Zoom as well. Thank you very much to all those who have joined us. I also welcome Professor Farisa Wakar, who's the co-chairperson of Rawalpindi Islamabad SOGP chapter, and our executive member, Professor Nabia, has also joined us on Zoom. Brigadier Maimuna was here. Unfortunately, we lost her due to some technical issues. Madam, first of all, there was a discussion going on Facebook comments about Zantac, ranitidine. So any comments that you would like to give, Professor Ghazala or Professor Batul, any one of you? There has been a ban on ranitidine, Zantac, recently. So quite a few people have mentioned that. What about Zantac?
I think ranitidine was banned by FDA for some side effects which were, I think, very well advertised. Do you know the side effects? Do you
Madam, an impurity, NDMA issue hai.
Locally, is it
something I can't remember the exact code.
Is it a local? Is that a local ban, or is that an FDA?
I think a market it's not available in Pakistan as well, because recently the ban was imposed, but it was, like you said, well advertised and propagated. Apparently, with the storage at higher temperature causes this, contaminant or impurity to build up in the stores of ranitidine. And they are investigating that, so they have put a ban on that. So this is for the information of everybody.
Is that a local ban or is that an FDA ban? I had some, reservations on it.
So it's a nitrosodimethylamine, NDMA. That is all. So, Professor Farisa Wakar,
Yes.
can you start your
hear me?
video? Yes, I can
Yeah.
hear you, but we cannot see you. I think आपने video on नहीं की हुई अपनी.
नहीं, आपने वो किया है, इधर ये लिखा हुआ आ रहा
नहीं
है
नहीं मैडम, एक मिनट.
कि
Let me ask you
लेकिन
to
you
start your
cannot
video.
start.
Let
The
me
host
let me
has.
let me ask you. जी अस्सलाम वालेकुम.
जी
We can
वालेकुम
see you.
सलाम जी.
अस्सलाम
Always
वालेकुम
pretty in pink.
अस्सलाम वालेकुम, कैसी हैं आप? पहले मैं फेसबुक पे थी, फिर मुझे साइमा ने कहा जूम पे आ जाएं.
मैडम हम आपको देखना चाहते थे ना, in the beautiful
सही.
print that you are wearing.
Oh, thank you so much. आपकी all the presentation, both the presentations were very good. मैडम गजाला ने बहुत बेसिक और बहुत डिटेल में जो प्रेगनेंसी में प्रॉब्लम्स आते हैं, as soon as the patient starts off her pregnancy, she starts having, you know, nausea, vomiting, dyspepsia, regurgitation, loss of appetite. ये सारा कुछ फौरन शुरू हो जाता है और majority patients को होता है. बहुत कम पेशेंट्स होते हैं और जिनको नहीं होता बेचारे ये परेशान होते रहते हैं कि कहीं ऐसा तो नहीं है कि प्रेगनेंसी अच्छी नहीं है तो इसलिए नहीं हो रहा, या हेल्दी प्रेगनेंसी नहीं है तो इसलिए शायद उनको नौजिया वगैरह नहीं हो रहा. तो ये एक कॉमन परसेप्शन है. प्रोफेसर बतूल ने जो हमें कोविड के बारे में बताया, मैंने जो आई ओनली सॉ 2 पेशेंट्स, my own patients who delivered normally, and they both of them had GI symptoms. दोनों को सिर्फ जॉन्डिस था, देखने में नजर आ रहा था जॉन्डिस, आईज उनकी स्क्लेरा येलो हुआ था, एंड बोथ हैड डिरेंज्ड LFTs. और इनिशियली उस वक्त ज़ाहिर कोरोना नया नया आया था, दिस इज लाइक एंड ऑफ मार्च अप्रैल, आई थॉट कि ये शायद हेपेटाइटिस ई है. And although hepatitis E is also very infective, we kept the patients in, thank God, in isolation. And later on, the COVID was positive. So this is, and then I read through that LFTs are deranged in COVID-19 also. दूसरा जो स्टूल में जो पास होता है वायरस, 50% have virus in the stools, and people who are sharing washrooms, they should not be doing that. और तीसरी बात मैं ये कहना चाहती हूँ कि पाकिस्तान में right now they are saying that the cases have gone down, and I hope it stays that way. But as Professor Batul said, we all have to live with COVID-19 now. Probably this will come back. I hope, inshallah, it does not. Or even if it comes back, it's very mild and we don't have the spikes again. So let's hope that in future it's going to be better. जर्ड के बारे में ये कि ट्रीटमेंट क्या देनी चाहिए, इट्स वेरी डिफिकल्ट. फर्स्ट ट्राइमेस्टर में पहले तो हम रेनाटिडीन दे देते थे, अब इसोमेप्राजोल इस तरह की चीज़ें फर्स्ट ट्राइमेस्टर में देते हुए ऑनेस्टली आई फील वेरी जिटरी गिविंग इसोमेप्राजोल इन द फर्स्ट ट्राइमेस्टर. So probably we would give something like Mucain or Gaviscon or something like that, which would help the patient. But usually with these syrups, patients do not, with antacids, they do not improve so much. And sometimes it becomes a problem with the patients and they are very upset about it. So what we have to reassure them, and they want to take it. अगर हम नहीं भी देते तो खुद ही मेप्राजोल और इस तरह की चीजें खा लेते हैं मरीज. तो इसके बारे में प्रोफेसर बतूल, वुड यू लाइक टू आंसर कि हमें फर्स्ट ट्राइमेस्टर में इसोमेप्राजोल देना चाहिए कि नहीं? आई डोंट थिंक सो, बट मेरे हिसाब से इट्स नॉट अ गुड ड्रग टू गिव इन द फर्स्ट ट्राइमेस्टर. दिल नहीं मानता और कैटेगरी बी ड्रग है, वो सी है, सॉरी कैटेगरी सी है, तो इसको फर्स्ट ट्राइमेस्टर में देना मेरे ख्याल में अच्छी बात नहीं है. एंटासिड्स वगैरह पे गुजारा करना चाहिए.
बिल्कुल सही है, बिल्कुल सही है. और ज्यादातर किसी का भी एक्चुअली उनकी तबीयत खराब तो नौजिया वॉमिटिंग से होती है. गर्ड इतना फर्स्ट ट्राइमेस्टर में यूजुअली नहीं होता, और वही टोटकों से और जो हम सफेद शरबत देते रहते हैं, डाइजेक्स, म्यूकेन, मुख्तलिफ किस्म के, काम चल जाता है, काम चल जाता है.
बिल्कुल
अनकॉमन है, हेयर एंड देयर मे बी 100 या 200 में एक आदि को हम दे देंगे, बट वी अवॉइड.
लोकल रेमेडीज में जिंजर वुड बी इज अ वेरी गुड ऑप्शन. जिंजर का या तो वो मैं पेशेंट्स को यही बताती हूँ छोटे पीसेस करके मुंह में रख लें, या उसका वो एक पहले तो आता था उसका एक्सट्रैक्ट मिलता था उसका, लेकिन आजकल जो है इट्स नॉट अवेलेबल जिंजर का एक्सट्रैक्ट. तो चलें उसका कावा बना लें या उसके पीसेस करके मुंह में रख लें, वो एक ऐसी चीज़ है जिसका कोई प्रॉब्लम कोई नहीं है, कोई साइड इफेक्ट नहीं है, हमें पता है, और वो आराम से इट डज हेल्प द पेशेंट्स। जितनी प्रीवियस रिसर्च हुई है उसमें यही पता चला है कि जिंजर डज हेल्प इन दीज gastrointestinal symptoms of patients who are especially in first trimester of pregnancy. जी Saima?
जी madam. I saw Professor Nabia joining it, but she was walking in the corridor of her hospital.
I'm still
Professor
walking.
Nabia, assalamu alaikum.
Assalamu alaikum. Assalamu alaikum. Thank you so much organizing committee, especially because this is most common problem, especially in pregnant women. आप जब हिस्ट्री नॉर्मली अक्सर अगर आपके जूनियर रेजिडेंट्स ले रहे होते हैं हिस्ट्री, दे डोंट आस्क द पेशेंट कि भाई आपको है, और वो मिस भी हो जाता है. लेकिन अगर आप whenever you ask the patient कि आपको GI symptom, GERD या कुछ ऐसी चीज तो नहीं है, तो they are. Am I clear? जी, तो यूजुअली these symptoms अगर आप ना पूछें तो पेशेंट नहीं बताती. पेशेंट जैसे फरीसा ने कहा कि
जी मैंने आपको
जी, तो ये पेशेंट के साथ होता है. आप अगर नहीं भी पूछते हैं तो पेशेंट समटाइम्स फॉरगेट्स टू मेंशन हरसेल्फ कि भी उसको ये प्रॉब्लम है, बिकॉज दे कंसीडर दिस नॉर्मल. और आई डोंट नो, मुझे लगता है कि हमारा जो लाइफस्टाइल है ना, द टाइप ऑफ फूड हमारे घरों में जो पकता है, प्रॉपर जो 3 टाइम्स मील है, अगर आप पेशेंट को थोड़ा सा गाइड कर दें स्मॉल फ्रीक्वेंट मील्स पे, फ्रूट्स और नट्स वगैरह को ऐड कर लें रादर देन रोटी सालन और इस तरह की चीज़ें आप लें, या जिस तरह के सालन हमारे पकते हैं, तो इनको अगर आप अवॉइड करें, स्पेशली ड्यूरिंग प्रेगनेंसी जब आपका स्टमक इतना काम नहीं कर रहा होता, मे बी दैट कैन बी हेल्पफुल. लेकिन पूछें ज़रूर. पेशेंट समटाइम्स फॉरगेट्स टू टेल यू कि उसको ये इतना सिवियर सिम्टम है, स्पेशली फिर जब वो अनीमिया के साथ आते हैं. जब आप डिटेल हिस्ट्री लेना शुरू करते हैं तो कहती है जी मुझे तो थ्रू आउट खाया ही नहीं गया because of these issues. So this is very important. आपका anemia prevention के लिए भी एक good dietary history and history of reflux and all these things.
Thank you very
और
much,
बाकी
Professor
तो
Nabia.
it was very informative. प्रोफेसर गजाला ने, मैडम ने, इन्होंने तो बहुत डिटेल में हमें भी सबको पढ़ा दिया, और माशाल्लाह it was very informative and useful, I hope, for everyone. Thank you so much.
प्रोफेसर आफ्ताब मुनीर का एक मैसेज आया है कि आई वुड लाइक टू थैंक both my great friends with great presentations which were very good and informative. Professor Aftab Munir.
We are honored.
So sweet.
We are honored. We are honored.
Professor Farisa, you were saying something.
I was just trying to thank you, Saima, for organizing all our meetings. It's very kind of you. You're always there to help us. और आप इतनी अच्छी तरह organized होता है ना. All the things which you conduct are so well organized. You're so particular of each and every detail. And I want to thank Professor Ghazala Mahmood also and Professor Batul. Such informative lectures. These are very common things which happen in pregnancy. And you know, patients are actually very upset with these symptoms. तो इसलिए उसके ऊपर highlight उन्होंने किया दोनों madams ने, and it was very very informative. And I'm sure all those who are hearing, मैं देख रही थी कोई 107 लोग थे, इतने थे, they must have learned a lot from this. और मेरे ख्याल में हमें अगर पेशेंट को थोड़ी सी काउंसलिंग भी कर देना कि ये आपके साथ होना है, आप थोड़ा सा जो है ना इसको बर्दाश्त भी करें. आजकल बच्चियां भी थोड़ी, आपको पता ही है, जल्दी अपसेट हो जाती हैं कि क्यों मुझे इतना हो रहा है, मैं कुछ खा ही नहीं सकती. तो उनको थोड़ा सा अगर हम काउंसिल भी कर दें कि दिस इज गोइंग टू हैपन एंड यू हैव टू बी लिव विद इट. थोड़ा जैसे प्रोफेसर नाबिया ने कहा, लाइफस्टाइल मॉडिफिकेशन कर लें, फ्रीक्वेंट स्मॉल मील्स, और बहुत घी वाली चीज़ें ना खाएं. इस तरह की चीज़ें उनको अगर हम काउंसलिंग अगर करें ना, कई तो मैंने खुद मरीजों को डॉक्टर चेंज करते हुए देखा फर्स्ट ट्राइमेस्टर में. जी वो तो कोई फ़ायदा ही नहीं हुआ. उन्होंने गोली दी थी, ना उल्टियाँ बंद हुई, ना मेरा तेज़ाबियत बंद हुई, और मैं ना भूख लगती है मुझे. और डॉक्टर ने अच्छी दवाइयाँ नहीं दी. उनको समझाना चाहिए एक दफ़ा कि ये होएगा, प्रॉबली 12-13 वीक्स तक ख़त्म हो जाएगा फर्स्ट ट्राइमेस्टर के बाद. तो फिर मेरे ख्याल में उनको बेहतर उनकी आउटलुक होगी रिगार्डिंग दीज सिम्टम्स. थैंक यू सो मच.
Thank you very much, Professor Farisa. Professor Ghazala, Professor Batul, is there anything that you would like to add before we wind up this session?
But I
I
think
think
I would.
हाँ, जी पहले मैडम आप बोलिए.
I think I would like to thank Saima, because I think Saima has been working on this webinar for the last 48 hours endlessly. And I think the amount of energy and work she puts in, it's not possible for everyone, and the commitment she shows. Thank you so much, Saima, and thank you, Batul, for your lovely lecture and your lovely comments, Farisa and Nabia. And thank you, last but not the least, Gets and Dr. Aisha Patel and the Gets team for giving us an opportunity to listen to and talk to each other. Thank you once again.
मैं मैडम ने सबका शुक्रिया कर दिया. I would just like to thank all the participants who have joined us. It is a very tough time. This is the siesta time, the sleep time, and you have it is the thirst of knowledge which is joining us together. And the SOGP Rawalpindi Islamabad chapter welcomes all the people who are on the Facebook as well as on the Zoom. And I hope it was a good learning experience, and I hope we continue with these activities. Thank you all, and thank you, Gets Pharma.
Thank you very much.
Thank you, Professor Ghazala, and thank you, Professor Batul. You've always been very supportive, and your guidance is always there for all of us. And every time it's we are learning new things. So technology tests us every time, but somehow Allah Ta'ala helps us. We are able to put it all together because working as a team. So thank you very much to our worthy speakers and the great audience that we have had, and our other senior members who joined us, and a lot of appreciation for Gets Pharma for supporting all the academic activities that are going on and training us as well. So I hope this continues. Thank you very much, everybody.
Thank you.